So our next speaker is Mr. Richard Kerr. He's a consultant neurosurgeon at Oxford University Hospital's NHS Foundation Trust. He's also the chair of the Royal College of Surgeons Commission on the Future of Surgery. So I can't think of anyone more qualified to speak on the future of surgery. Over to you, Richard.
Thanks very much for that kind introduction. I'm very pleased to be here, so thank you to the organisers for asking me to come and speak to you this afternoon. We're at the start of an amazing revolution. So if you go back to the early 90s, the number of connectable types of devices that there were in the world was about 1 million at that time. As we enter the 2020s, there are now over 50 billion connectable devices that are available for people to interact with. Now, this has been described, therefore, as the fourth industrial revolution that we're now going into. And this is about cyber-physical systems that we're now working with. We've gone beyond the electronic age into the next age of digitization. Now, of course, that applies to everything. It applies to the world of finance. It applies to the world of industry. It applies to commerce. And within that fourth industrial revolution, there are changes as a result of augmented reality, cloud computing, mobile devices, smart sensors, changes in 3D printing, and so on and so on. Now, clearly, this doesn't just apply to the world of industry and commerce. This applies to the world of medicine as well. And indeed, it's already happening. Earlier on last year was the first report of a patient in China who had surgery using 5G with a robot when the patient and the person operating the robot were separated by 1,800 miles. So this sort of technology is already being utilized, and it was on that basis that I was asked to put together a group of individuals sponsored by the Royal College of Surgeons to begin to look at what these technologies meant to the delivery of surgery over the next 10 to 20 years. So this talk is relatively short, and what it will do, I think, is just give you an overview of some of the areas where we think there'll be change, but also just begin to talk about what we need to do to try to train the workforce to make sure that we can get the best utilization of these changes in techniques as we go forward. So the commission that I put together was established in 2017, and what it aimed to do was to try to collect together all the various different innovations that were there to see how they would impact and work together. And the commission was comprised of these colleagues, some of whom were surgeons, but about half were not, but they were experts in epidemiology, in microbiology, molecular biology, in IT. There were people from the public sector, from innovation, from administration, and obviously junior staff as well. The evidence we received was enormous, with over 70 written contributions, with 4 days of oral evidence sessions, and they're all available on YouTube if you are bored one day and want something to look at. What is apparent is that these changes are going to impact on every aspect of the patient's journey through starting off with healthy patients and hopefully prevention of disease, through disease prediction, early diagnosis, and then treatment and follow-up. And what's really important whenever we're thinking about this innovation is that we remember that there's a patient absolutely at the heart of this, and everything that we do, therefore, has to have the patient dedicated in the center. So the major findings of this were, firstly, that the big changes are going to be because of digital technology, but also our biological understanding of disease and treatments, particularly from the advances made in genetics. What's also true is this is going to affect every type of surgery. It's not just colorectal surgery or urology. It's going to be across the board. And it means that we have to think about how we're going to train surgeons and surgical teams to take best advantage of this and how we're going to deliver these aspects of care. The hope, of course, is that surgery will become safer and less invasive. And the particular areas where we saw change coming were with genomics and big data, with imaging, simulation and the immersive platforms, and then obviously with minimally invasive surgery with robotics. And then there's one or two other areas that I'll talk about, like stem cells. So again, I can't go through all of this, but if we just look at genomics, for example, genomics is going to impact every stage of that patient cycle that we just talked about, from early testing, newborn screening, looking at disease susceptibility, trying to predict those who are going to get disease, screening and diagnosis, and then looking at the prognostic and therapeutic impact of that genetic knowledge in terms of outcome from our surgical procedures. Now, if you just take one example of that, would be looking at liquid DNA, for example. Many tumors will secrete portions of DNA into the bloodstream that can be picked up and identified now. And this potentially provides a way of earlier diagnosis, earlier identification of tumor and tumor processes, and therefore, hopefully, earlier treatment, and maybe even non-surgical treatment if we can pick up these tumors early enough. If you look at big data, there's an awful lot being talked about the use of big data and data analytics. Where are we really trying to go with that? Well, I think we're going at various different levels with this. There's an enormous amount of information coming from electronic patient records, from the genomic data that's being collected through the cancer registries and other registries, and there will be information that's available on public health websites as well. Now, if you begin to analyze all of these data, the aim would be that we will be able to much better predict what we think disease and disease process is going to do. But more than that, ultimately, the holy grail has to be that we can get to a point where we can personalize the care that we're offering to patients by analysis of these large data sets. And I think there's every chance that we should be able to achieve that. If you move on to the simulation, we're already beginning to use simulation much more for various techniques. The old idea of learn one, do one, teach one when it comes to surgery is no longer applicable in the 2020s. We can't do that anymore. So we need to use simulation for our techniques as much as possible, and that simulation needs to be in a team-based environment. This is from the Royal College of Surgeons of Ireland simulation lab in their new building in Dublin, where they actually bring in the whole team looking after patients. The teams are videoed doing simulated procedures with then a discussion afterwards as to how that went. And obviously, if we then move on, we can move into the world of virtual reality and actually practice our techniques in virtual reality. When the issue of haptics has been resolved, then our ability to practice those techniques with haptic feedback, which means we can then move on much quicker in that immersive world. Teaching and training also becomes much easier when we can utilize this as a way of actually training as opposed to the way that we currently do. Now, obviously, this is, as I said, it's just a snapshot. I can't go through all this in detail. So what about minimally invasive surgery and robotics? At the moment, there's over 100 robots being used up and down the country. If we look at the number of robots per million of population in some of our European colleagues and countries, they're roughly 3 times the number of robots that we have. So we are potentially under-roboted. However, the robots that we currently have are only being used about 40% of the time on average. So what about robotics? Are robotics going to take over the world? Well, I don't think so. So why do we want to use robots? When I first started asking that question, the answers I was given were because of accuracy and precision, because of ease of access to various areas of the body, because of the amazing visual display with 3D magnification that it brings, because of the ergonomics for the surgeon. It's much more comfortable. You're sitting in a seat. You don't have these difficult effects as regards trying to get into odd positions. Because the impact on tissues is less, faster recovery times, and hopefully less pain with 2 S's, not 1. However, I didn't think that was enough for us to be looking at these devices, which can cost, as you will well know, large amounts of money. And I think the potential benefit from the use of robots and robotics is with less variation in outcome. It's hopefully going to narrow that Gaussian distribution of outcome when it comes to looking at the procedures that we undertake. The problem about it is the cost. They're not cheap. The instrument costs, the portability, although some of the newer types of devices, as you know, are much more portable. There is an issue about training and the associated costs with that, and that's something that we're heavily involved with at the college, and the issue of evidence of effectiveness. I think there is increasing amounts of data in the literature, but that is predominantly in the urology literature. I think there is some more literature coming in the world of colorectal surgery and cardiac surgery, but in terms of solid evidence of effectiveness, we've got a way to go, and that again is something that we're trying to do at the college. I couldn't leave minimally invasive surgery without mentioning nanorobots. I've had some discussions, particularly with colleagues on the East Coast of the US who are running a nanorobotics program, and that too is in its infancy, but it's getting there, and there are issues about delivery of nanorobots and then recapturing them afterwards, depending obviously on what they're being used for. But that's a new and exciting field of technology. Of course, there are some specialized interventions like stem cell therapies, which you'll be well aware of, artificial organs, animal to human transplants is certainly a topic of conversation at the present time, and then obviously neural integration when it comes to limbs. So those are the sort of areas where we see the big changes happening. So how's all this going to be delivered? Well, the answer is it's going to be delivered, I think, through a surgical team. And the team-based approach is very much, I think, the way forward in the future. And there will be a whole range of people involved in that team, including our colleagues in anesthesia, who will be known as perioperative care physicians as opposed to anaesthetists in the future. The delivery of treatments is almost certainly going to be competency-based as opposed to an individual. So will it always be the surgeon doing that episode of care? Probably not, particularly if there's someone in the team who has the competencies that are appropriate to deliver that. So how will the surgeon change in the future as a result of this? Firstly, I think the surgical career is going to become much less distinct. I had a career that pretty much was doing neurosurgery 5, 6, or 7 days a week and not much else. I suspect that our careers of the future will be much more portfolio in nature, and there will be opportunities to do other things, indeed, and even an expectation to do other things. There will always be a need for cold-face surgeons, absolutely, but I think there will be much more flexibility and diversity in the careers. Surgeons are going to need to understand the language that comes with the expansion of particularly the world of genetics when it comes to discussing patient treatments and outcomes. Team working will be even more important, and we need to be training in teams to do that. And then I've mentioned this one at the bottom, is there a greater role for non-surgeons when it comes to delivering episodes of surgical care? The benefits for patients, if we are able to adopt these technologies, this is, I think, the most important one, early detection of disease using all of these platforms. And if we can detect disease at a much earlier stage, we're then talking about moving from organ-removing treatments to organ-sparing treatments in our surgery, which can only be for the good. Faster recovery times, less invasive surgery, ability to operate on older and frailer patients, and obviously we are an aging population, and the patients who are therefore in need of treatment tend not to be in the urban conurbations, as often population demographics demonstrates that people are actually moving into the coastal areas in the country rather than staying in cities. So we need to be able to get our treatment out to them. Shorter waiting times, yes, it's an aspiration. We can only hope that that will occur. So if we just look at something that's common with all of these technologies that we've been talking about, what does that actually mean? Well, these are the commonest procedures that we do in this country at the present time. Cataracts is by far the commonest operation, apart from tooth extraction. So forgive me if there's any colleagues from the world of dentistry or maxillofacial surgery in the audience. I'm going to stick with cataracts for the moment. 400,000 cataracts are done each year, 2 million over a 5-year period. So if we take that common procedure, what does this kind of mean for someone who has a cataract? Well, firstly, there's going to be increasing demand given our population demographics. We've all got 2 eyes, we're all living longer. A lot of us are going to get cataracts on the way. Almost certainly, the use of AI will increase when it comes to actually making the diagnosis. And more than that, it may enable us to stratify the risk that a patient will actually need their cataract dealt with and how quickly that might come. Improved lens design, we're already moving to smart lenses. That actually means that these will adapt to our requirements. Augmented reality platforms for training, and the president of the Royal College of Ophthalmologists suggested that specialization of surgeons, I'm not going to get into that. If we move forward 10 to 20 years, demand continues to rise. AI diagnosis will almost certainly be routine by that point. Robot-assisted surgery will be a way potentially of us being able to do these very delicate procedures in the numbers that are required. Remote surgery, possibly, but almost certainly will be at a time when we can use stem cell therapy to replace the lens itself. So if you just take cataracts, we've actually talked here about minimally invasive surgery. We've talked about AI and the use of big data. We've talked about stem cell therapies, and we've talked about augmented reality when it comes to actually delivering the surgical treatment. So all of these areas that I've talked about have actually been covered by the commonest operation that we deal with. Alvin Toffler wrote some years ago that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So we are moving into a time of change, a time when we have to be able to adapt to the changes of innovation that are coming, and we have to be able to train the workforce to enable us to do that. If you look at the Topol review that was published just about a year ago, the conclusions out of Topol were very much that the surgical curriculum needed to be reviewed, but it had to have agility for change throughout it. There needed to be a knowledge of these other areas, not just of surgery. In other words, there needed to be a knowledge of IT, data, engineering, genomics, and so on, and an acceptance of this career flexibility with the importance of mentoring and proctoring because of the change. And that these changes will affect the whole workforce. It's not just the surgeons, it's all of those who are working surrounding the surgeon as well. There needed to be time within our training programs for training, dedicated time. And the hope, of course, is that there will be a much more diverse entry into med school. Now, that's already happening at the postgrad level, but whether that can be brought into the undergrad level as well. In terms of the Future of Surgery report, when we put this together, our output from this, and thankfully it was published before the Topol review, were that there needed to be quite significant curricular change with a change in the way that we're teaching and training our surgeons and surgical teams of the future. We needed to have standards for introduction of new devices and new techniques, and I think that's really important, and it's something, again, that we're trying to work on. The patterns of care were moving much more towards early, preventative, organ-sparing surgery rather than playing catch-up, which is what we so often are having to do at the present time. The sustainability agenda, which wasn't covered in the document, is one that is certainly increasingly important. And the issue about green theatres, the issue about where our instruments are coming from, the issue about how we deal with waste, and so on. And then all of that needs to be based as much as we can on research and data collection and the analysis of that. Now, if we look at just the teaching and training very briefly, we're currently undergoing an exercise within the college to say, what does a surgeon and surgical team actually look like in 20 years' time, and how can we change what we do so that make sure that we're training people in the right way to be flexible and to be able to accommodate the changes that we're talking about. So there's an active program of working going on with med students and trainees for us to try to understand that. There's various things that are already in place, like a series of e-learning projects that are being put together with an expert advisory network to look at how we incorporate some of this stuff. We're working with HEE, with the Immersive Technology Initiative, to see again how we can begin to train people from the future. And what we want to do is use much more virtual reality teaching and simulation. What we mustn't forget is the importance of these skills of communication, skills of team building, and human factors training. As regards robots, as I said, we're doing quite a lot of work with the commissioners and with HEE and developing some teaching platforms with robotics companies so that we can try to make sure that there is a standard level of training before robots are introduced into our operating theatres up and down the land. There are 4 domains, I think, for robotics within the HES data set, and we're beginning to look at the HES data sets to try to draw out some of that information. We've already started a research project looking at integrating immersive technologies and training surgeons, something called the Mastery Project, which is being joint run between the University of Birmingham and Newcastle with the Royal College. So we're trying to be as active as we can because we feel that these are the areas that are going to be so important if we're going to bring in these new technologies. So in the long run, do I think that robots and avatars are going to take over the world? Well, actually, I don't. And I'm going to finish with something that came from a guy called Professor Weizenbaum, who some say is the forefather of AI. He sadly died, but he wrote that there are some things people come to know only as a consequence of having been treated as human beings by other human beings. And that is something that you can't replicate in a robotic or mechanical world. What we need is compassion, empathy, and the human touch to remain ever present while we are moving forward with these amazing innovations. Thank you very much indeed.